Lata Venkatesan, an iconic visionary leader. Now I request Dr. Lata Venkatesan, Professor cum Principal, College of Nursing, AIIMS, New Delhi, to address the forum.
Thank you, Dr. Cecilia. I must be thankful to the speaker, Dr. Judie, for consenting to address the gathering on simulation-based nursing education and best practices in it. I know Dr. Judie underwent a very rigorous and structured training in USA. She volunteered herself to go there and be there for a month, and then she has gained all the skills in simulation. She is also elevated as director of simulation-based nursing education in her parent institute. So we welcome Dr. Judie, and we are all eagerly awaiting to listen to you. I'm sure it's going to be a great learning experience for all of us. And CNRS North Zone is very happy to host monthly research excellence webinars. And from national level speakers, we are moving on getting international speakers. So we will have good learning experience drawn from other countries. Thank you very much.
Thank you very much, Lata ma'am, for introducing me. I was working as a faculty with Lata ma'am, and Lata ma'am is my mentor as well. I am really thankful to Lata ma'am and organizers for inviting me for this webinar. Shall I start?
Ma'am, 1 minute, I will introduce. Ma'am, please.
Okay, fine.
I cannot share my screen. Pratigya? Miss.
Yes.
I'm not able to.
Just a second. Just a second, ma'am. Yeah, you can do it.
Yeah, thank you. Is my slide visible? Is my slide visible?
Visible, go ahead, please.
Yes, ma'am. You can put it in a slideshow mode.
Yeah. We have with us an eminent speaker and an eminent nursing personality, Dr. Judie Arulappan, who has who is an associate professor and director of Nursing Laboratory and Simulation Unit. Madam has got Doctor of Nursing Science from Milan, Italy, and also she has obtained PhD in nursing from Tamil Nadu Dr. MGR Medical University. Ma'am has a lot of honors and awards which are awarded by different institutes. She has been best teacher, and she has been awarded with an exceptional performance in teaching, best teacher award by MGR University, Apollo, and lifetime achievement of doctorate award, and also Rashtriya Vidya Saraswati Purashkar. Ma'am is a very simple, down-to-earth person, great orator. We are very much privileged to have you, ma'am, with us amongst us today. With your expertise, we are hearing, we will learn a lot from you. Over to you, ma'am. Thank you.
Thank you, Cecilia. Can I share the screen now? Yeah. Is my screen visible to everybody? Hello?
Not yet, ma'am.
Not
No,
yet?
No.
Now? Can you see it?
ma'am,
Mm.
it is like coming down. It's starting, ma'am. Not its screen is not. Ma'am, it's visible.
Visible?
Yes, ma'am.
Can I start?
Yes, ma'am. Please.
Okay, thank you. A very good evening to everyone. I'm so happy and privileged to be here in today's webinar. And at the outset, I would like to thank Dr. Lata Venkateshan, who is the organizing chairperson, and Ms. Cecilia, organizing secretary, and Dr. Muthu and Pradigya madam from CBS Publishers, and all the EC members of Clinical Nursing Research Society. Thank you everyone for having invited me to be here today for this webinar. So I'm going to talk to you all today about simulation in nursing education, the best practices. Hope I'm audible to everybody.
Yes, ma'am.
There is some something it's disturbing my screen. Okay, fine. Now hope it is clear now. Okay, so I am Dr. Judie Arulappan. I am currently the Director of Nursing Laboratory and Simulation Unit, and as I am working as Associate Professor in the Department of Maternal and Child Health, College of Nursing, Sultan Qaboos University, Oman, and these are my contact details. So before starting my presentation, I would like to share my humble experience in simulation. Since 2016, I was involved in simulation-based teaching, both in simulation and OSCE in the College of Nursing, Sultan Qaboos University. And I was trained by Dr. Jennifer Bartlett, who is a simulationist from the USA. And I completed OSCE training program in Oman. And I also completed International Visiting Scholar Program in Simulation in Duke Center of Nursing Discovery, Duke University, North Carolina, USA in June-July 2022. And I also completed the course on simulation, the standards, core competencies, and best practices in healthcare simulation offered by Society of Simulation in Healthcare, United States of America in August 2022. And currently I am pursuing another course, which is a 6-month certification course, which is offered by INAXEL, which is named as INAXEL Simulation Education Program, ISEP. And currently I am undergoing that course in USA. And I am holding professional membership in INAXEL since August 2022. And also I'm holding professional membership in Association of Standardized Patient Education since August 2022. I'm also a professional member of Society of Simulation in Healthcare from 2020 until till date. And I regularly conduct and publish simulation-based research, and I formulated research groups in simulation. This is how I am just keeping myself updated about simulation, because as I am working as the director of the simulation unit, I should keep myself updated with the current knowledge. That is the reason I am just undergoing all this training and keeping myself updated. So with this humble experience, I'm going to share the best practices in nursing education, simulation in nursing education. So these were my mentors in simulation. When I visited US to the Duke University, I had Dr. Nikki Pestas, who was my primary mentor, and Dr. Valerie Howard, she's my secondary mentor, and Dr. Marguerite Malloy, she trained me in interprofessional simulation. They were my mentors in simulation in the United States of America. So this is going to be the outline of my presentation today. I'm going to introduce simulation in nursing education. So I will be sharing about demystification of misconception about simulation, responses of simulation survey conducted in 2022, foundations of patient simulations, healthcare simulation standards of best practice, CHSE, CHOS certification process, membership in professional simulation organizations, research priorities for simulation-based research, and SSH accreditation process. So you all know I don't have to explain what is the definition of simulation. However, just to start my presentation, I would like to briefly define simulation. Simulation is a process by which we try to achieve the results by approximating the clinical practice as closely as possible in the simulation lab. So here we are doing the simulation for the purpose of practice, learning, evaluation, testing, and to gain understanding of systems or human actions. So what the students are doing is the students are putting everything they have learned into practice. So they are able to make mistakes without causing damage to the patients. They are able to practice in a safe environment without any risk for the patients. Also, simulation promotes the critical thinking ability of the students and it improves the clinical competence. Why? Because the students are practicing the skills as well as the scenarios in the laboratory through the process of experiential learning through deliberate practice. Repeatedly, they practice until they get the confidence in practicing the skills directly on the patients. Therefore, this is a kind of experiential learning through deliberate practice. So the simulation also enhances the team spirit, communication skills, and spirit of cooperation. How it is improving the team spirit, communication skills, and spirit of cooperation? Because we conduct interprofessional simulation, we invite people from other healthcare students as well as we invite healthcare professionals who are working in other professions. We invite them to the simulation lab. We make them to work together in a scenario so that during this process, the students as well as the healthcare workers, they learn the team spirit, communication skills, and spirit of cooperation. And moreover, the current trend is interprofessional simulation, interprofessional education, collaborative practice, all are the current concepts of clinical education and practice. Therefore, we can enhance this team spirit, communication skills, and spirit of cooperation through interprofessional simulation. And when we do the simulation, it minimizes the errors, it increases the satisfaction of students, and it increases the self-confidence, self-esteem, and comfort in skill performance for the undergraduate and graduate nursing students. So ultimately, simulations reduces the students' anxiety and fear before they directly practice on the patients. So in 2009, the journey started, and in Excel, they created the standards of best practice. They developed the Excel standards. So they started the Excel standards of best practice. So the latest version is updated in 2021. If anyone is interested to know about the Excel standards of best practice, please visit this particular website where you will be able to find the Excel standards of best practice. And if anybody who is novice in simulation, if you wanted to learn more about simulation, please visit this particular, you can click this link so that you will be taking to, the link will take you to the healthcare simulation dictionary. From this, again, you will learn the various terminologies used in simulation. So now I would like to demystify misconceptions about simulation because many people have a wrong conception about simulation. When I was back home in India also, because I had zero knowledge about simulation, because I never practiced simulation, I never had any exposure to simulation when I was working in the previous institutions where I was working. So when I came here, it was really shocking. It was shocking for me when I was put into a course where I am supposed to use simulation and OSCE. I was having a zero knowledge about simulation and OSCE. However, I was in a situation that I have to learn simulation and OSCE. Therefore, I got from 2016 onwards, I got into many training programs, and that is how I just got into the simulation program and many of the simulation experiences. So from 2016 only, I started learning about simulation and associated experiences. So I would like to demystify some misconceptions people have about simulation. So actually, the National Council of State Boards of Nursing, we call it as NCSBN, it conducted a survey in 2014. So this survey, which is called as National Simulation Study, it demonstrated that high quality simulation experience could be substituted for up to 50% of traditional clinical hours. Why? Because they conducted survey across many nursing programs. They identified that they replaced 50% of the traditional clinical hours with the simulation hours. And they identified that it is very effective for the pre-licensure program, which is a BSN program. And considering these results, Singapore Nursing Board, they substituted 160 hours out of 400 clinical hours, that is 40%. They implemented simulation in the final year nursing students with the clinical practicums with simulation. And again, in 2016, a study which was conducted by Curl et al., he wanted to keep 50% of clinical experience for the simulation. So he wanted to employ a strategy 1 hour of clinical practice is equal to 2 hours of clinical experience. 1 hour of clinical practice. 1 hour of clinical practice is equal to 2 hours of simulation experience. Why? Because during simulation, the students are completely immersed into the simulation situation because they have no distraction. Completely, they are learning. They are into a learning situation. Therefore, this 1:2 can be utilized in the simulation experience. That is how this study concluded at the end of 2016. Therefore, if you see many of the institutions, they consider 1 hour of clinical practice, which is equal to 2 hours of simulation. So that is how this can be taken into consideration because they are getting an immersive experience in simulation. And also many studies proved that repeated simulation experiences enhances the self-confidence, critical thinking competence of nurses and nursing students. It is not only boosting the self-confidence and critical thinking and competence of nurses, it also increases among the nursing students. And also in most of the studies, students reported satisfaction with the simulation experience and usually reported higher self-confidence after simulation experience. In our university, we are using 20% of hours for simulation-based education. So we are in the process of upgrading this simulation hours. However, now we are using 20% of hours in the simulation-based education. Coming to the responses of simulation survey in 2022, when I took over this position as director of the simulation unit, I was curious to know how people are using simulation, what are the needs of the faculty in simulation. So I conducted a simulation survey. So in the simulation survey, I basically asked two questions. What type of simulation scenarios do you use in simulation? And what are your training needs in simulation? So in that, the faculty responded that 54.5% of faculty, they were using uncommon cases in simulation. 50% of them used unseen cases in simulation. And 22.7% of them responded that they used simulation for teaching invasive procedures. And finally, 36.4% of them said that we use simulation for teaching complex patient care needs. And I was surprised to know that the training needs in simulation, because almost everything the faculty wanted to learn because it is totally new to them. Therefore, all these INACSL standards of best practice, pre-briefing, simulation, debriefing, scenario development, simulation design, virtual simulation, virtual reality, standardized patient methodology, simulated patients, trends and latest technology in simulation, knowledge in simulation, fidelity in simulation, evaluation in simulation, interprofessional simulation, membership in simulation-based organization. All these were faculty wanted to learn about this. Thus, I started the training program from last semester to train our faculty about simulation. Last semester, I organized a training program, and this semester also, I'm going to organize a training program for our faculty to update their knowledge and skills in the simulation. So now let us see the foundations of patient simulation. So it will be really interesting to know how we started the simulation. Actually, from infancy, if you see, we practice sucking and rooting reflexes through giving a pacifier to the children. Especially if you see the neonates, we give a pacifier, which is essentially a part task trainer that simulates a mother's nipple. That is the starting point of our simulation. And if you see the military, in military they used war simulation, and war games were conducted to prepare for actual battles. And aviation has been using simulation to teach flight control. So almost in all the fields, simulation has been used. So now let us see about the modes of simulation in nursing education, because this is our focus. So in this, first one is part task trainers. In part task trainers, we use the head, arm, extremities mainly to practice skills such as starting IV line, suturing the leg, pelvic trainer, urinary catheterization, rectal exam, and so on. So that is called as part task trainers. Then human patient simulations. So we use many terms, which is like the human patient simulation. It will be exactly mimicking the real life patient. So we use different terminologies for this human patient simulations, like high fidelity patient simulators, mannequins, medical simulators, nursing simulators, OB simulators, surgical simulators, pediatric simulators. These are various human patient simulators which are available. Then simulation with standardized patient, because there will be a patient who will be acting like a patient, who will be a real human being. So they are called as standardized patients. So we also use simulation with standardized patient, which will give high realism, because it will be more realistic like a real patient. So therefore, the high level of realism and simulation can be achieved when you are doing simulation with the standardized patient. And also we have virtual reality, which is like a computer generated environment with scenes and objects that appear to be real, making the user feel they are immersed in their surrounding. And we have hybrid simulation, where we will use a combination of live and virtual simulation or different modalities. Say, for example, we will use a standardized patient and a task trainer. In case, because recently I happened to see a hybrid simulation where there is a standardized patient who is a lady, who is a real human being. So she was keeping a birthing simulator in her abdomen, and exactly she was sitting in a sitting position, and she was simulating like a labor process. So she was giving like she was giving sound, she was crying, and she was pushing, and she was exactly delivering the baby as though she's delivering the baby, she was enacting. So it was more realistic. This hybrid simulation was more realistic for the students to learn through this hybrid simulation. And apart from that, we have distance-based and virtual simulation, which is otherwise known as computer-based simulation. And we have bioskills, where we use human and animal tissue. And we have in situ simulation, which is conducted in the hospital. In our college, in our university, we also conduct in situ simulation for a nursing administration course. So we take the students to the hospital. In the real hospital environment, the simulation is conducted. So we tried with one course, and it is very successful. Since 2 semesters, we are implementing this in situ simulation. So if you, for the novice nurses, I just took some pictures for you to understand better about this. So these are some examples of part task trainers. So as I mentioned in the beginning, these are examples of part task trainers. These are the human patient simulators, which is exactly mimicking like a real patient. These are examples of virtual reality, which is in the 3D environment. And this is hybrid simulation. If you see the picture, the lady is a real patient, and she is using a part task trainer. And if you see this man who is undergoing a LP, he is a real patient, but there is a part task trainer upon which the student is practicing. And this is an example of distance-based simulation or virtual simulation. When I visited Duke University, I found this simulation, which is very interesting, where the nurse, because they're in US, they have nurse practitioner programs. So the nurse practitioners were from different parts of US, and the simulationist is from Duke University, and the standardized patients were from different parts of the US. So everybody was from different parts of the world, but they were connected through this distance-based or virtual simulation. Whereas I saw a case of tick, because the mother is taking care of a child who is suffering from tick, and the mother was explaining about the child's symptoms. The child was exactly acting like a child with tick, and the nurse practitioner was trying to diagnose the case. And at the end, the simulationist or a facilitator was trying to debrief, and it really went on so well. So I really enjoyed this technology in Duke University. And this is the picture I took when I went there. So this is for a distance-based simulation. So this is an example of bioskills, where we have a human, especially for the practicing anatomy, physiology, things like that, we can go for this bioskills kind of trainers. And this is an example of in situ simulation, which is happening in the hospital. So now let us come to the important part, which is healthcare simulation standards of best practice. So this healthcare simulation standards of best practice, it was initiated by INAXL with the INAXL board of directors, and they introduced the standards of best practice. So this healthcare simulation standards of best practice, it consists of the following 10 standards. So as simulationists and simulation educators, we must know all these 10 standards compulsorily. Without knowing the 10 standards, we cannot conduct an effective simulation. So the first one is professional development, pre-briefing, simulation design, facilitation, the debriefing process, operations, outcome and objectives, professional integrity, enhanced IPE, and evaluation of learning and performance. So recently in the latest edition, the first and second standards were introduced. Before that, there were only 8 standards, but in 2021 edition, professional development and pre-briefing were introduced in the healthcare simulation standards of best practice. So let us see the first one, which is professional development. For example, I explained about my humble experience in simulation. because as a simulationist, I have to say that I am competent in simulation. If I have to say that I am competent in simulation, only when I am developing myself professionally. So I did, because I followed this particular step, because I have to keep myself current and updated. So that is what we do in the professional development. So here, what the standard says, the simulationist should stay current with the new knowledge, and they should provide high quality simulation experiences, and they should meet the educational needs of the learners. So there are many organizations which specify the need for educator training. For example, the Association for Standardized Patient Educators, the Association for Simulated Practice in Healthcare, the National Simulation Guidelines for Pre-Licensure Nursing Programs, published by the National Councils of State Boards of Nursing, Healthcare Simulation Standards of Best Practice, Certified Healthcare Simulation Educator Standards, Society of Simulation in Healthcare Accreditation Standards, National Organizational Nurse Practitioner Faculties, the Canadian Certified Simulation Nurse Educators Competencies. All these compulsorily tells us that the simulationist should stay current with the new knowledge. So how we can meet this standard? As I did, we have to do an educational needs assessment. So as I did for our faculty, the need assessment survey, the first thing is educational need assessment should be done. So therefore, we will do a gap analysis. So we will identify what is the gap which is existing in the simulationist. So based on that, we have to develop professional development activity. After developing the professional developmental activity, we have to reevaluate the professional development plan. So definitely, as I mentioned, we have to pursue the professional development based on the identified learning outcomes. And we should incorporate current best practices in the daily practice. And we should contribute to the body of knowledge and simulation, especially through publications, editorials, empirical research, blogs, social media, and presentation. And we should partner with the colleagues in the field to present the session, poster, or workshop. And we should also pursue something called as professional certification through simulation organizations like SSH, Society of Simulation in Healthcare, because there are some certification called as CHSE, Certified Healthcare Simulation Educator, Certified Healthcare Simulation Operations Specialist, and Advanced Degree. All these can be done through SSH. Also, there are many other formal education programs available, which is offering certificates and academic degrees. For example, Drexel University, it provides an online course, which is Master of Science in Medical and Healthcare Simulation. University of Central Florida, it offers Nursing and Healthcare Simulation online program. And there are many fellowships which are available for online 3 months and offline or in person 6 to 12 months. So currently, as I mentioned, I am pursuing something called as ISEP, which is a 6-month certification. So these are various methods through which we can develop ourselves. And apart from that, we can incorporate peer review and mentoring, and we have to collaborate with others in the field of simulation. So when you are becoming a member of the simulation organization, automatically we will get connected with the professionals in simulation. Because say, for example, now I am a member of ASPE, SSH, and INAXL. I am in touch with many simulationists across the world. That is how we can get connected with people in simulation. And the second one is pre-briefing. Pre-briefing, I want you to understand the meaning of pre-briefing. Pre-briefing is preparation and briefing. It includes 2 elements, the preparation and briefing. So here what we have to do, there are many other terminology we use for this pre-briefing: pre-scenario learning activities, pre-planning sessions, briefing session, preparation session, pre-simulation preparation, pre-briefing, briefing, pre-simulation, there are many similar terms are used by different people. All these indicates pre-briefing. So for example, in the preparation, what we have to do as nurse educators, we should be demonstrating the skills involved in simulation, and we should be orienting the students to the laboratory, and we should prepare the standardized patient before the simulation. Say for example, there should be a pre-briefing room. In the pre-briefing room, we will take the students and we will explain about the simulation situation to the students. And we will also take the students to the simulation lab. We will orient the students to the simulation lab and we will prepare them. So that, and the standardized patient who is going to work with this has to be prepared. What is the script he should speak? What is the standardized patient dialogue he should talk? All these should be prepared with the standardized patient preparation. Say for example, I can, as a teacher, what I can do a role modeling, instructor model learning, or expert modeling by showing motivational interviewing. So I can show the students how to do a motivational interviewing with the patient who is drug abused or alcohol use or who is a smoker. So I have to do motivational interviewing, and I should show him, so that the student will be exactly able to do that when it in the actual simulated situation. So therefore, we should use a consistent, pre-planned, standardized written briefing script so that the students will learn through that. So we call that as a pre-briefing booklet or pre-briefing checklist. So therefore, the simulationist should be knowledgeable about the simulation scenario and the concepts of pre-briefing. Also, it should be based on the purpose and learning objective, and the experience and knowledge level of the simulation learner should be kept in consideration. Why? Because we have to have different objectives for different levels of students. So we should always keep that experience and knowledge level of simulation learner should be kept in consideration. And this pre-briefing will be giving more of psychological safety to the students, and it decreases the learners' anxiety. And novice learners request more time for preparation briefing because they are new to the simulation. So we need to take more time to prepare them than the expert simulation users. And also we have to use variety of activities in the pre-briefing. If you see, all these are some examples for pre-briefing activity. I can create a Moodle page and I can upload all these in the Moodle page, or I can provide them a file with all this information so that it will become a pre-briefing booklet or pre-briefing activity. So I can keep assigned readings or audiovisual materials, concept mapping or care planning exercises, review of patient health record and patient report, case studies, observation of a model of a simulated case, completion of a pretest or quiz, review of medication, practice of skills, and lecture or other didactic lesson, clinical preparation sheet, discussion of simulated patient, virtual simulation activities. All these can be a part of pre-briefing activity. So therefore, in this pre-briefing period, I would like to say about important thing. We have to tell the participants about their roles and expectations. So we should be assigning the role badges. Say, for example, there are 5 participants in the simulation. So 5 of them should be given role badges. So each of them will be given a role badge mentioning whether she's a primary nurse or a caregiver or a medication nurse or a patient, whatever it may be. They should be assigned the role badges, and the role badges can be assigned either on a random basis or based on the preference. So after this, also we should get the consent from the participants, especially we should tell them that it is going to be recorded, because recording is mandatory for simulation, because that will be used for the debriefing activity. So we should get the consent, because without the consent, we should never record the event, because some students feel embarrassed. So we should get a written consent before doing the recording. So especially we should tell them that it is going to be observed by the peers, faculty, facilitators, staff, health professionals, administrators. Everybody is going to monitor it. So therefore, I need your consent for the recording. So with the recording only, we can record it. And also we should orient them to the technology. And we should tell them what is this mannequin looks like, what is this virtual learning environment, this is screen-based learning, these are the commercial learning products. All these should be explained to the participants. And we also should create a psychologically safe environment, telling that feel comfortable, because it will not create any negative consequences, because it is only for learning purpose. That level of psychological safe environment should be created. Also, we should explain about the evaluation methods which is going to be used in the simulation, so that the students will be prepared that I'm going to be evaluated in the formative evaluation. I'm going to be evaluated in the summative evaluation, whether it is going to be used for the high stakes examination. All that has to be explained to the students. Also, we should discuss the fiction contract with the learners, which is very important, because it is a kind of unrealistic situation, but the student should feel that it is real. That is the reason we should get the signature in something called as fiction contract. Though it is unreal, they should experience that as a real situation. That is the reason we are getting a fiction contract agreement signed. Also, we should be discussing the procedure of confidentiality agreement and video recording for the students. Why? Because the simulation scenario should not be leaked. Say, for instance, if there are two groups of students. So if I am sharing, if I am just running a simulation for one group of students, if I am running the same simulation for another group of students, the information should not leak out. Why? Because the other group of students will not understand it is a realistic way. That is the reason we should get the signature for the confidentiality agreement. They should not leak out the scenario. Or if at all, if you are planning for a new another group, you have to create a new simulation scenario. Otherwise, if there is no confidentiality, the students will not take it seriously. That is the reason we are requesting for the confidentiality. Then this is a very important thing I want to highlight in the pre-briefing, because suspension of disbelief. Because as I mentioned, it is an unrealistic situation. We are making it as, we are approximating as closely as to the clinical situation. So here we can suspend the disbelief of the learners through some processes. First one is fidelity. Fidelity is called as, there are different fidelity or realism. So when you are creating a simulation scenario, the physical or environmental fidelity should be maintained. Functional fidelity, psychological fidelity, and conceptual fidelity should be maintained. If you see what is conceptual fidelity. So when you are preparing the scenario, it should be really mimicking a real hospital situation in the concept. That is called as conceptual fidelity. What is psychological fidelity? It refers to the degree to which the trainee should perceive that simulation is believable. For example, if there is a situation like a death, so this situation should be created exactly like a dying situation. The student should really feel the shock, and the student should really understand it is a death. So that kind of psychological fidelity situation should be created. So what is functional fidelity? It refers to the realistic responsiveness of the simulator. Because say, for example, the mannequin's lung sound should improve after the chest physiotherapy. That means functionally the students are understanding that the mannequin is changing the lung sounds following the chest physiotherapy. What is environmental or physical fidelity? So the equipment, supply, sounds, the staff, setting, everything exactly should be mimicking the hospital environment, so that we create a physical or environmental fidelity. Sometimes what happens, the students may not be knowing where the items are, where the articles are in the laboratory. So we can create a game for the students like scavenger hunt. So what we can give a checklist to the students, and we can tell them, please go and identify where these items are located in the laboratory. We can give a game, and we can ask them to just go around and search for the items, so that the students will identify the articles where it is located. So it is a kind of orientation to the students to the laboratory by giving a game called a scavenger hunt. And also we have to create fiction contract. As I mentioned, in order to suspend the disbelief, we have to get a signature in this fiction contract. So they should realize that it is real before, during, and after simulation. The third one is psychological safety, because we have to ensure the psychological safety with the students. You have to say it is mainly for learning purpose, and you should never feel embarrassed, and you should not feel about the failure. Even if you're making mistakes, there is a time for correcting it. So you should make them to feel very comfortable in the laboratory. And there is something called as emotional buy-in. Emotional buy-in is something, the experience of an emotional attachment to the scenario. For example, as I mentioned, sense of urgency of a simulated court situation. Imagine you are creating a simulated situation of a simulated court situation. The student should run around and they should work as though there is a real emergency happened. So in that situation, they are emotionally getting attached to the simulation scenario. That is called as emotional buy-in. And assigned meaning. The students also should be assigning the meaning to the scenario based on their psychological and social experiences. And additional determinants for suspension of disbelief are, so say for example, if a student is giggling during the simulation, they know it is unrealistic. If they are giggling during the simulation, we should understand the attitude of the learner. So in that situation, we should give some cues at that situation. Is that something going wrong? Are you feeling uncomfortable with any of the situation? Things like that, we have to give a lead to the student so that the student will stop giggling. So that kind of cues can be given to stop giggling during the simulation activity. Also, we should understand the personality differences such as attentiveness, impulsivity, anxiety level, and extroversion of the personality of the learner. So all these factors should be considered when you're suspending the disbelief in simulation. So these are some steps to suspend the disbelief before the simulation-based learning activity. For example, we should prepare clear, detailed learning objectives, and we should be also creating a realistic, believable simulation environment, and we should establish an environment of trust and mutual respect, and we should establish partnership with learners, and we should establish fiction contract. We should do a proper pre-brief, and we should clarify the doubts. All these are the activities which can be done to suspend the disbelief before the simulation-based learning experience. So the second one, this one is very important, simulation design. This is a very important part of simulation where it is a framework for developing effective simulation-based experience. As I mentioned, the first step is the simulationist. Say, for example, if I am a simulationist or a simulation educator, I should be knowledgeable on the best practices in simulation education, simulation pedagogy, and practice. So if I am not having sufficient knowledge in the simulation, I will not be able to develop a proper simulation scenario. So for this purpose, we should do a needs assessment and we should examine the knowledge, skills and attitude and behavior of individual and what are the organizational needs and clinical practice guidelines, patient safety goals. All these should be considered when you're doing a need assessment. Based on that, we can identify the needs. Then after identifying the need assessment, we should construct measurable objective. That objective should be it should address the identified needs and optimize the achievement of the expected outcomes. So then we have to build the simulation-based experience based on the objectives. And the modality should be chosen according to the objective. For example, as I mentioned in the previous slides, there are various modalities available. For example, simulated clinical immersion. Here, we will create a situation exactly like a hospital situation in the lab, and the students will be immersing in that particular situation. And as I mentioned, in situ simulation, exactly we will do the simulation in the hospital setting. And computer-assisted simulation, virtual reality, procedural simulation, hybrid simulation, or it is going to be with the standardized patients or mannequins or with the avatars or with the partial task trainers. We have to decide on this modality. So based on the level of the learners, and we have to decide the modality of the simulation. Then we have to design a scenario or case or activity which has a realistic starting point. And so when you have a realistic starting point, only the students will be able to accept it as it is. That is the reason the situation and backstory should be providing a realistic starting point. Then we also should be preparing ourselves to give cues for the learners. So the cues can be given through verbal cues and visual cues and by additional data. How I can give verbal cues? So through patient, through the provider, or to the embedded participant. Say, for example, during the simulation, if the students are getting distracted, some cues will be given through the patient. Patient will say something, or the healthcare provider will say something, or the embedded participant will intervene and say that this is supposed to be done. Something, they will just intervene and they will give a cue for that student to pick up. Then visual cues also will be given, like say, for example, we can make changes in the vital signs on the monitor. And by also we can provide additional data like new laboratory results, something like that. We can give cues for the learners during the simulation. And as I mentioned earlier, the fidelity is very important. We should maintain the physical fidelity, conceptual fidelity, and psychological fidelity. The physical fidelity can be in terms of the simulator and mannequin, standardized patient, environment, and equipment. In conceptual fidelity, as I mentioned, it is all elements of the scenario or case should be as realistic as possible. And psychological fidelity, the realistic conversation, the realistic noise and lighting, everything should be made in such a way that psychologically the students feel that it is a real hospital setting. Then facilitation is an important process during this, because the facilitator is the person who is running the simulation. So the person should be planning for the proper debriefing, proper debriefing, and the cultural diversity of the learner should be considered. For instance, I would like to say an example. Among Muslim women, shaking hands with opposite sex is forbidden. Imagine there is a scenario where you are a healthcare provider. You are supposed to give good afternoon, Aisha. If you're just trying to shake hands with the opposite sex, it is forbidden. So that we should create a situation considering the cultural diversity, so that the student should understand I'm a male. I'm not supposed to give a shake hand to a female. So this is a way the cultural diversity of the learners should be kept into consideration. So we have to have a perfect pre-briefing plan, debriefing plan also. Everything should be made perfectly readily available in the simulation design. So this is an example I would like to show. When I visited Duke University, I saw this culturally inclusive care, because there are mannequins which is dark skinned. There are mannequins which are white skinned. The students are given scenarios considering the cultural diversity. So there, when they go, the way they communicate to the patients, it differs, because the communication, when you're communicating to different people from different countries and different continents, it differs. So they have to talk considering the culture of the patient. This is something which is interesting, which I found in the US. So finally, we have to develop a plan for evaluation, because the student also should know this is going to be a formative examination or summative or high stakes examination, so that they have to understand this is how I'm going to be evaluated. And lastly, we have to pilot test the simulation based experience. Why? Because when we run the real simulation, sometimes we may make mistakes. So when you do a pilot testing of the simulation based experience, you will be able to understand what are the technical problems you may encounter, or what is missing during the pilot testing. So we can rectify that when the pilot testing is completed. All these should be considered when you're doing a simulation design. So the next one is called as facilitation. Facilitation is nothing but the faculty who is involved in the simulation should be providing a structure and processes to guide the participants. Why? Because she has the responsibility in the oversight of the entire simulation-based experience. For example, the facilitator should have thorough knowledge about specific skills and knowledge in simulation pedagogy. That is very important because she should have proper experience so that she will be able to prepare the simulation accordingly. Also, she should use a facilitative approach. For example, because she should understand the learning needs of the participants, experience of the participants, the competency of the participants. So she also should be able to select the proper modality and proper fidelity when she is choosing the simulation. And she should be able to properly select the evaluation data. All this is very important. As a facilitator, she should be aware of this. So therefore, she should be able to create a psychologically safe environment, and she should be able to do a pre-briefing at a designated time. For example, I would like to say about it. Say, for instance, if I am doing a pre-briefing, during that, imagine that I am going to teach, I am going to do a surgical dressing during my simulation. So before the simulation, actual simulation, during the pre-briefing, so the students will be trained to do the surgical dressing before they go into the actual simulation, so that the students get more hands-on practice in the surgical dressing, so that it is the job of the facilitator to make sure that the student is well prepared in performing that particular skill before going into the simulation practice. And she also should be knowing about the predetermined cues and unplanned cues, because the predetermined cues, as I mentioned, the verbal cues, the visual cues, all I mentioned about the predetermined cues. But unplanned cues are sometimes called as lifesavers, because it is not planned actually. What will happen during the simulation? Some sudden changes will happen during the process, because the students will do something which may be deviating from the actual scenario. So say, for example, in that particular situation, you can give some unplanned cues like laboratory results, mollage, phone calls, comments from the patient, family member. All these can be done as an unplanned cues, so that the student will be directed into the proper simulation technique. So all these are very important. Finally, the facilitation should be done with a debriefing process, and the facilitator should be aware of the different debriefing process which has to be done by the participants. So now coming to the debriefing process. What is the debriefing process? Debriefing process is a planned activity which is bidirectional, formal, collaborative, and it's a reflective process. This debriefing can be conducted with feedback, debriefing, and guided reflection. Why this debriefing is done? Because it is helpful for developing the insights, improve the future performance, and promote the transfer and integration of learning into practice. So you may have a doubt whether I have to use any specific strategy for this level of students or not. There are various strategies available. However, we can combine one or two debriefing strategies into a particular simulation. Or if you feel that plus delta is the best strategy for level 1 learners, you can go for plus delta. If you feel that gas model is good for the third level of students, you can go for the third level with the gas model. So it depends upon that. It depends upon your experience also. You can design which is the best debriefing method which can be used for your learners. So therefore, in the debriefing, you have different phases. First one is called as description phase. Here, the learners are demanded of the objectives of the simulation and purpose of debriefing. In the reaction or diffuse phase, it allows the learners to explore their reactions to the experience. During the analysis or discovery phase, the facilitator will assess the learner's exploration into the experiences, facilitates the understanding of material, and helps to identify the knowledge gaps. And finally, in the summary or application phase, the debriefer will provide opportunity to recap the experience, identify the insights, and allow for the exploration of how this knowledge, skill, and attitude can be transferred to the actual patient care environment. Therefore, these are very much useful to transfer the learning to the actual patient care environment. So as I mentioned, this the feedback, guided reflection, all these can be done to gain understanding and insight into the simulation scenario. And also it can promote the linkage of theory with the practice and research. And this can be encouraged through journaling. We can ask the students to write, as well as we can ask them to openly discuss the situation. So the main criteria is to meet debriefing is, for example, the person who is debriefing the simulation should be competent. They should be knowing how to do a feedback, how to give a debriefing, how to do a guided reflection. So unless and otherwise they know that, they will not be able to give a proper debriefing. So there should be, therefore, the debriefing should be planned and incorporated from the beginning when you are formulating the simulation scenario, so that it should be a planned and structured activity wherein you are giving an opportunity for the students to understand the gaps in the knowledge, and you can bridge the gap between the theory and the practice. That is very important. So various debriefing models are used. For example, I just would like to highlight some examples for you to understand. Debriefing for meaningful learning, DML we call it as. Debriefing with good judgment, diamond model, gas model, which is gather, analyze and summarize, Pearls model, then we have a Pearls framework and Pearls model, plus delta model, reflect model, 3D model of debriefing, critical incident stress debriefing model, learning conversation, situation-based impact intent. These are some examples. So there are many instruments which can be used to assess the debriefing process. So these are some tools which are actually available. For example, DASH tool and debriefing for meaningful learning evaluation scale, feedback assessment for clinical education, objective structured assessment of debriefing, peer assessment debriefing instrument, simulation effectiveness tool modified. All these are the tools which can be used to evaluate the debriefing. So coming to the next one, operation. Operation is something it is dealing with the infrastructure, people and process, because there should be dynamic collaboration which should be happening between leaders, simulationists, educators and learners. And it has adaptive relationship between the departments. So in this operation, we should make 3 levels of planning. So immediately we have to do a strategic plan considering the immediate needs up to 1 year, short-term needs up to 1 to 5 years, longer term and future sustainability or growth needs for 5 to 10 or more years. Also, we should develop an organizational infrastructure where we should consider the leadership, administration, management operations, technology specialists, educators, instructors, facilitators, and simulationists. All these people should be available to run the simulation center. So then personnel should have appropriate training. Say, for example, they should have designated job description and they should be trained because they should be always kept updated. So they should be trained and updated for their professional development. And we should also develop plans to manage the space, equipment, and personnel resources. We should consider the financial resources because many of the organization, this is the main constraint. Financial resources is the main constraint to start the simulation because it is quite expensive. So this has to be kept into consideration. However, simulation is the best educational strategy to bridge the gap between the theory and practice. And also, I would like to say that we should have policies and procedures to support and sustain the simulation-based education program. For instance, there is something called a systems integration. Why? Because we are teaching simulation in the college. However, in the Duke University, I observed there is the simulation unit for the College of Nursing and Hospital are collaborating very actively in the simulation because the faculty working in the clinical area are the clinical instructors who are teaching the nursing students. So therefore, there is a complete collaboration between the College of Nursing and the hospital where there is no chance for there is limited gap between the theory and practice because the clinical faculty, whatever they are doing in the practice, they are exactly teaching in the simulation lab also. And this kind of system integration can be done. Say, for example, the clinical faculty are bringing high-risk clinical situations to the College of Nursing, and they are simulating the situation, and they are filling the gap through the simulation. So this is the best practice which I observed in Duke University, which we can also do because after me coming from there, I started encouraging our faculty also to do this system integration, which is very much beneficial. Then coming to the next one, outcomes and objectives. This is nothing but the outcomes should always align with the objectives should always align with the objectives because ultimately the objective should end with the outcome. So therefore, whenever you are formulating the outcomes, it should be influenced by the accrediting bodies, program, clinical agency, course, or patient care needs. So for the learners to achieve the intended objectives or outcomes, so we should be creating valid and reliable scenarios. So this will be bringing change in the knowledge, skills, and attitude of the learners. So therefore, during the simulation design, learning objectives are developed in alignment with the Bloom's taxonomy. All of you know about Bloom's taxonomy, which has knowledge, skill, and attitude domain. Also, we should be formulating SMART objectives, which is specific, measurable, assignable, realistic, and time-related. So this is very important. So coming to meeting the criteria, there is a model we can follow, a World Kirkpatrick's model, which has the following components: reaction, learning, behavior and results. So this model can be formulated when you're formulating the learner outcomes. So during the reaction, it measures the degree to which the training is favorable, engaging and relevant to their jobs. In the learning process, it measures the degree to which the learners acquire the intended knowledge, skills, attitude, confidence, and commitment. In the behavior stage, it measures the degree to which learners apply what they learned during the training. And in the results phase, it measures the degree to which the targeted outcomes occur as a result of training, support, and accountability. So similarly, we should create objectives which is meeting the defined outcome, and we should identify the appropriate simulation modality, as I mentioned in the previous slides, and we should identify the appropriate fidelity, and we should develop guidelines for facilitation of simulation-based experience to meet the objectives. And the next one is professional integrity. This is very important when you're conducting the simulation, because the faculty, the facilitators, learners, participants, everybody should be following some ethical standards or ethical behavior while conducting simulation. So this is actually enforced by Society of Simulation in Healthcare, which published the first healthcare simulationist code of ethics, and the Association of Standardized Patient Educators, which addresses the safe work environment, and values and ethics, which is a core competency of interprofessional education collaborative. So therefore, everybody involved in the simulation should be following the ethical standards. Say, for example, whether it is an embedded simulation participant, learners, faculty, patients, program staff, everybody should be following the ethical behavior. So therefore, we should consider the integrity, transparency, mutual respect, professionalism, accountability, results orientation. So all these standards of practice should be followed, and we should create a safe learning environment where everybody feels comfortable, and we should consider the principles of equity, diversity, and inclusivity. As I shown that picture, that is one of the ethical consideration which is considered during the simulation. The black children and white children, so that color difference, and then a student should be able to identify the needs of that particular clinical situation. That is an example how we are considering equity, diversity, and inclusivity. And also we have to maintain the confidentiality of the performances and scenario content during the simulation. So the next one is simulation enhanced interprofessional education. It is nothing but where we just invite the healthcare workers as well as healthcare students from different professions to engage in a simulation-based experience. So here it should be definitely this simulation-based interprofessional simulation should be following some theoretical conceptual framework. There are many theories upon which we can use this simulation, interprofessional simulation. For example, in our College of Nursing, we are using NLN Jeffrey simulation theory. I have already published a paper about how we have integrated NLN Jeffrey simulation theory into the simulation and how it is effective. Already I published, and it is getting good citation also. Also in the interprofessional simulation, we have to adopt team steps. Team steps is something which is an evidence-based set of teamwork tools where it is optimizing the patient outcomes and it is improving the communication and teamwork skills among the healthcare professionals. Also, as simulationists, we should recognize and address the potential barriers for simulation-enhanced interprofessional education. So this is the NLN Jeffrey simulation theory, what we are using in our College of Nursing. And also we should devise an appropriate evaluation tool for the interprofessional education. These are the various tools which are available. I have just given these tools names for your reference, because all these tools can be used to evaluate the simulation enhanced interprofessional education and collaboration. Also, finally, we should investigate the effectiveness of SIM-IPE after the curricular integration. And last one is evaluation of learning and performance. So because ultimately we are trying to measure the knowledge, skills, attitude, and behaviors through the cognitive, psychomotor, and affective domain. So it can be either formative evaluation to foster the development and assist in the progression. It can be either summative evaluation, which focuses on measurement of outcomes and achievement of outcomes, objectives, and it can be high stakes evaluation. High stakes evaluation, for example, for a merit pay or progression of grades, they do simulation for high stakes evaluation. In all these ways, the simulation can be used for formative evaluation, summative evaluation, and high stakes evaluation. So these are the standards of best practice. Now I really, because as I am novice to the simulation, I just started the process of certification process. Now I am preparing for the certification. Therefore, I thought the many people who are interested in simulation you can also go for the CHSC, CHOS certification process. So I thought this will be a very useful information for all of you. So the CHSC is called as Certified Healthcare Simulation Educator. This certification can be done by any individuals who are interested in simulation. For example, you should have the basic criteria is you should possess a bachelor's degree or equivalent combination of education and experience. You should have minimum 2 years of continued use of simulation, either in the healthcare education, research, or administration. And you should get 3 letters of recommendation from simulation experts. After getting the recommendation letter from the experts in simulation, within 90 days, you should take the exam. So the exam centers are available in Oman. We have examination center in Oman Medical Specialty Board. I think in India also it may be available. So within 90 days, this exam should be taken. And the exam fees is $395 for members of Society of Simulation in Healthcare. And it is $495 for non-members. And optional practice exam is available for $75. It is available for 30 days. And the test consists of 115 multiple choice questions. So in that 100 questions will be counted towards the passing score. And the exam is for 2 hours, but additional 60 minutes will be given to candidates from non-English speaking countries. So the re-exam can be taken for $175 for members, $275 for non-members. And individual, you can take maximum of 4 times repeatedly because the exam is quite tough. So until you pass 4 times a year, you can take the exam. So you have to pay the fees again and again, and you can take the exam until you pass the exam. So it is valid for 3 years, and you can go for recertification, and you can also go for advanced certification. For advanced certification, you should have 5 years of experience in simulation. And various benefits are there for CHSC certification, because now I am trying to go for the certification. But if anybody is interested in doing that, please contact me. So I will be able to guide you through that process. It definitely enhances the knowledge, attitude, practice, everything through simulation, because it is going to be support for the institution, for yourself, and it is going to be keeping yourself updated in simulation. And you can add this in your designation. Say, for example, when I'm writing myself, Judie Arulappan, MSN, PhD, CHSC. If I am passing CHSC, I can add that as a, that CHSC certification can be added in my designation. So that is a very important benefit of CHSC certification. And I also would like to encourage you to become a member of professional organizations in simulation. We have Society of Simulation in Healthcare, which is called as SSH. The individual membership fees is $185, and that is membership per year. The bulk membership, 5 to 9 members, means $175.75. So it has also various benefits. You can get access to the bi-monthly journal, Simulation in Healthcare. You will get connection with worldwide SimConnect people, SSH network, and you can become a mentor and mentee. And you'll be getting developing leadership skills, and you'll be able to participate in international committees. And there is live learning center, and you can go for CHSC, CHOS, and CHSC advanced certification programs through this membership. And it gives a new career opportunity for you in simulation. And if you can also become a member of INAXEL, the membership fees is $160 per year. And the institutional members, if you're 4 and more, $606 and lifetime membership is $1,600. It also has various benefits. So it say, for example, you can have a community of more than 1,800 members across the world who is more knowledgeable in simulation, and you can have on-demand CNE session. You can have discount on INAXEL products. You can attend INAXEL annual conference, and you can publish in Clinical Simulation in Nursing, which is an official journal of INAXEL. And you can also get discount for the membership in ASPE, SimGhost, then CISAM. All this you can get discounted membership, and you also can apply for INAXEL grants, awards, and research funding. Or these are the various benefits which are available in INAXEL. And finally, as ASPE, there is also Association of Standardized Patient Educators. So this is the membership fee. If you want to become an individual member, $135 per year. So it also has various benefits, including attending free work courses, webinars, conferences, committee membership. So you can be a part of special interest groups, awards, mentorship programs. There are various benefits. And my last presentation is priorities for simulation-based research. It is a 22-22 survey, where now all the simulation-based research is focusing on outcomes, patient outcomes. For example, the first one is effect of healthcare simulation level, simulation-based intervention on system efficiency, patient safety, and patient outcomes. return on investment, financial, social, health outcome, cost effectiveness of different modalities of simulation-based training and assessment, dose-response relationship between simulation training and impact on care process and patient outcomes, strategies to make simulation use more affordable, improve access to it and promote its implementation, factors, both facilitators and barriers in the institutional culture of healthcare organizations that determine the adoption of simulation for training and assessment, learner characteristics, instructor approaches, and simulation curriculum, scenario design, which maximize the learner acquisition, long-term retention, and transfer of clinical environment of technical and non-technical skills, and effect of simulation-based disease-specific training of patients and their families on patient self-care and outcomes, research designs ideal for simulation-based studies that investigate simulation effectiveness, simulation-based strategies most effective for error-proofing devices, procedures, environment, and healthcare systems, drivers and barriers to conduct high-quality educational and safety research using simulation technologies. These are the recent priorities in research which was identified in 2022. However, since most of us are new to simulation, I would recommend you to go into many of the research topics, which is at the basic level also, because I am doing some basic studies only now, because I am also new to simulation. So I'm not doing this advanced level of studies. I am doing basic studies, which is applicable to Oman. And these are some of the examples. It has plenty of information. Anyway, I can share the information later because due to the time constraint, I am just rushing through this. So these are the other priority areas of research where it discusses about theories of learning and teaching, theories of cognitive load, different simulation modalities, characteristics of debriefing, optimal use of video recording, differences in the outcome between the faculty-led debriefing and peer or self-guided debriefing, debriefing characteristics, learner motivation, cognitive, emotional, and social characteristics, simulation activities, theoretical concepts, and empirical findings. So there are many things which are available, which you can do at a basic level. So these are some examples I have just brought for your information so that you can, if anybody is interested in doing some research, so please take this information from me so that you can just start doing simulation-based research, which will be very useful for you because it has many information. That is the reason I'm not reading it out. So I have given the reference also. You can refer to this for more information. So finally, I would like to conclude my presentation by saying that simulation, we can take simulation lab also for accreditation. You might be surprised because for example, our institution is accredited by Accreditation Commission for Education in Nursing, United States of America. But as a lab, simulation lab is not accredited yet. So therefore, now we are in the process of going for Society of Simulation in Healthcare accreditation. So in this process, what we are doing is there are 6 areas for accreditation. So there is a core standard. Apart from the core standard, we have assessment, research, teaching and education, systems integration, and fellowship. So everybody should take a core for accreditation. Apart from that, we can either take assessment, research, or teaching and education as an accreditation. Now we are going for core and teaching and education because we are strengthened in those 2 aspects. So we are planning to go for the accreditation of these 2 domains. So depending upon the organizational effectiveness, organizational development in simulation, you can choose to go for accreditation. So if you have any questions, I'll be happy to clarify. So thank you for your patient listening. And I really thank the organizers for having invited me for this webinar. Hope I have given my best during this short span of time because it has so much of information to share. But as I was given only 1 hour, I have limited my talk within, I think, 1 hour, 15 minutes. Sorry for being late for 15 minutes. Thank you again for the opportunity. Have a good evening.
Ma'am, shall we take the questions?
Yes, sure.
There is. There are a lot of appreciations for you, ma'am. And one participant has asked, please explain for Indian student how we get this course.
1 minute, I will just close it. 1 minute. Can you please repeat the question?
Ma'am, how can I get this course for Indian students?
Course is possible, only thing it is a little expensive, but there are courses available in India also. I think there is some courses offered in Gurgaon, I think. Pardon?
Pedistars is also offering a course, and then SGT University is also offering a course on simulation.
So I heard about it, but I'm not very sure because, sorry, because I was not aware of those resources. Sorry. Any other questions?
Yes, ma'am. Mental health nursing people have simulation?
Yes, of course. We do a lot of mental health simulation because, say, for example, we do simulation on anger management, drug abuse, alcohol addiction. So we can do any simulation on the psychiatric also. Why? Because we have to have a standardized patient. Only thing is, standardized patient should be prepared in such a way that the standardized patient acts like a psychiatric patient, so that it will be more realistic. That is the reason when I was presenting, I mentioned that the high level of realism can be achieved in simulation only when you have a standardized patient. That is the highest level of realism in simulation. Okay, that is possible. Yes, any other questions? Please ask. I'll be happy to clarify.
Can you please give an example to go for high realism SME in community health nursing?
Community health nursing, exactly. Say, for example, in our institution, we are not exactly doing simulation in the laboratory. We do that kind of simulation in the community setup itself. That's what I told you about in situ simulation. Because in situ simulation can be done either in the hospital or in the community cell. Say, for example, out of hospital cardiac arrest. Imagine I am having a scenario about out of hospital cardiac arrest. I can really do that out of hospital cardiac arrest only in the community. So I can simulate a situation where exactly the students understand that this is the way the out of hospital cardiac arrest should be managed. So we will create a situation outside the hospital, outside the simulation lab, exactly outside, and they will really understand this is how we have to manage the situation. So for that, we should be training, because we train our students for BLS and ACLS when they go to the advanced clinical nursing course and critical care course itself, so that the students have that expertise when they go for the simulation of such kind of situation, they will be able to handle it. So that is how we are training.
Ma'am, one candidate has asked how to ask questions during debriefing session.
Yes, actually, if you give me another opportunity, maybe I can have a separate session on debriefing, because debriefing is not a simple topic. I have to have another 1 hour for me to explain the debriefing process. Say, for example, we can ask a question like, how did it, can you please explain how did it went positively, or what are the good points you can take from the simulation, and what are the areas of improvement? Say, for example, the way we ask questions should be in a non-threatening way, because we should try to get the information by asking Socratic questioning. It should not be threatening the students that why you didn't do this, why you did it. We should never ask such questions, because when you ask such questions, it is like a threatening question. So can you please explain what went on well? Can you please explain what can be improved? So this is a way we can put the questions to the students, so that the students will feel comfortable. Okay, my teacher is understanding me and she's asking a question in a very kind way. Let me openly describe it. So that is how we should ask questions in the debriefing process. We should never ask any harsh questions during the debriefing.
Yeah, yes. Very good, very well explained, ma'am. Within a short duration, it's like really. Ma'am, there is one candidate who have asked, can we have a model of scenario format followed there? Is there any standard format for designing scenario,
Yes,
or scripting?
We have actually, we developed a format for simulation because, say, for example, for the Bachelor of Nursing students and Master of Nursing students, we created a template. For example, the faculty, when they are creating the scenario, they should be fixing the content into that template. So for the pre-briefing, we have a pre-briefing checklist, and the pre-briefing checklist, we make sure that all the elements in the pre-briefing checklist is available. Similarly, whatever is supposed to be in the simulation scenario, it should be in the simulation scenario template. As well as they also should mention what debriefing they are going to use, which model they are going to use. That also should be made in the simulation scenario design. All these should be made available during this when you are designing itself. That is very important. Maybe I can share the outline, what are the essential elements which is supposed to be there in the template. I can do that. So ask them to contact me so that I will be able to definitely share my, whatever I can, I will do that.
Yeah, ma'am. Sure.
Any other questions?
Ma'am, there is another question. Difference between standardized patients and simulated patients?
Actually, it is almost the same. For example, standardized patient is more like a real patient where the patient, say for example, in our college, we invite participants who are workers, who are working in the restaurants, who are working in the part-time job, all they come and do because we give a standardized patient script and we train them. Okay. So in the simulated patient also, we can create, say for example, we create mollage. Mollage means artificially, say for example, bleeding for kind of exactly to mimic the real clinical situation. We simulate the patient in that way. So that we call it a simulation. Almost actually it is same, but it is used interchangeably in different literature. Okay, that is what is almost, it is almost same only, standardized and simulated patients. Any other doubts?
Yes. Is there any limitations with number of learners?
It depends. Say for example, we limit the number of learners. Say for example, in a particular simulation, we will not take more than 5 students in a particular situation. So 5 learners maximum, we keep them in the simulation situation, and remaining the classmates can be kept in the observation room. So they'll be observing from there and they will be doing a peer monitoring. So they'll be given a check-off, and the check-off sheet, with that they will be keeping everything, they will be monitoring everything. And after these 5 students finish the simulation, when they are taken to the debriefing room, the peers will be giving a debriefing. Along with the facilitators, the peer also will be giving debriefing for the participants. Yes.
Ma'am, there is one more question, like which type of SME is most cost effective?
Modality?
Yes, ma'am, simulation based.
Modality, okay. Cost effective, actually, standardized patient is more cost effective. But standardized patient alone cannot be, say for example, painful procedures, all that cannot be directly practiced on the standardized patient. So in that situation, we have to use some part task trainers along with the standardized patient. So however, the cost saving is standardized patient comparing to the simulators. A standardized patient, we may have to pay 1,000 real per day. 1,000 rupees per day. In our college, we pay 5 real. That means 1,000 rupees. 1,000 rupees for 1 hour. So like that we pay. So that is what we feel, that is less cost for that. Other than that, for every complex situations cannot be learned on a real patient. In that situation, we may use the mannequins, high fidelity mannequin. So we have medium fidelity, low fidelity, and high fidelity mannequin. So among this, low fidelity is less costly, high fidelity is more expensive. Okay.
Yes, ma'am.
Yeah.
Ma'am, there is a question: who is an embedded participant? Whether facilitator can be a part of scenario?
Yes, actually, the embedded participant can be anybody. Say, for example, imagine that I am a course coordinator. So the course coordinator is there as just observing. I am observing. I know the scenario and the background, everything. In that situation, in case if the student is deviating from the actual scenario, I can intervene. I can intervene and I can act as an embedded participant. Did you understand? Say, for example, I can just say, because I was telling an example of giggling. So I can say, is anything going wrong, which made you to giggle? Something like that. I can just casually, I can ask so that the student will understand the seriousness of it. That is called as embedded participant. Okay.
Yes, ma'am. Ma'am, next question. What type of research can be done for promoting simulation technique among faculties and students of nursing?
For example, now in Oman, our institution is leading in the simulation. However, as a beginning researcher in simulation-based research, I was just looking at the literature, whether there is any literature related to the knowledge, attitude, and practice of simulation educators in Oman. I couldn't find anything. When I was looking at the literature across the world, did anybody assess the basic level of knowledge, attitude, and practice of faculty about simulation? Then I found no literature, actually only one literature which is published in recently, I think 2 years back. Then I thought, let me do that, replicate that study in Oman. Because unless and otherwise I understand the existing knowledge and attitude and practice towards simulation among the simulation educators, I will not be able to understand the training needs of the people. So therefore, I am doing a need assessment survey, and also I am doing the knowledge attitude practice assessment among all the nurse educators in Oman, so that I will be, because it is a funded project, I got a funding for 3 lakhs. So with that funded project, I'm going to bring some information so that with that, I'm going to develop training programs for our faculty in Oman. So this is a basic thing which can be done because, for example, without understanding the needs of the faculty, you cannot organize any training programs for the faculty. Okay. Anything else?
Yeah, ma'am. There are a few more questions.
No problem. No problem. I'm happy to
Is
answer.
there any simulation available for neuro nursing, like managing RTA patients?
It is actually, it requires standardized patient because especially neurological, it cannot be exactly seen in a mannequin, right? So in that situation, we have to use a standardized patient. For example, for neurological examination, all we use the standardized patient. So in the health assessment course, for neurological examination, all we invite standardized patient, and the students usually do the neurological assessment and the standardized patient itself. That is the way we can do. But in the mannequin, it is quite difficult. Yes.
Ma'am,
Yes.
there is one more question, like how many students can participate in a scenario?
I mentioned that is 5 students. 5 students can be inside, maximum 5 to 7, because, you know, imagine a clinical situation. Can we have more than 5 members in the clinical situation? Maybe there is a doctor, there is a nurse, primary nurse, secondary nurse, there is a patient or a caregiver. Maximum more than 5, the scenario will not require more than 5. So that is the reason we limit with 5. Otherwise, it will be confusing and complicating the scenario. Okay.
Ma'am, there is one question. How color of mannequin affects in simulated scenarios?
Of course. Say, for example, cultural diversity. That is the reason I appreciated that technique in US, because they had both black and white mannequin. I was surprised to see, because there are black people and white people in that country. The students, when they are giving care for the patients, they should understand the culture of the patient. That is the reason the scenario mannequins itself was designed in such a way with different color. And when a scenario is given, the student should be able to understand this is a person who is from a black, who is a black. So therefore, they should be able to maintain the communication. Say, for example, there was an interprofessional simulation scenario which I observed. What happened in the interprofessional simulation scenario? The students from various disciplines came for the practice, and they created a situation where the patient is from a background. The patient will not maintain eye-to-eye contact with others, and the patient will be talking only to the husband. So he will not talk. She will not talk to others. So she was confiding everything to her husband only. The husband was sharing the information to the healthcare workers. So that was a kind of communication which was particularly available in a particular community. So that we have to create a situation where the students understand diversity and cultural diversity in the simulation. That is the reason these differences in the color in the mannequin will be very helpful. Maybe it may not be very applicable to our Indian culture, but in the other culture, it will be very useful. Because in Indian culture, we don't see that kind of differences. That is what. Anything else?
Thank you, ma'am. Thank you. I think with this, the question ends. CNRS North Zone President, Professor Dr. Lata Venkatesh. Ma'am, are you there? Kamlesh ma'am, would you like to say something? Yeah.
Hello.
Yes, ma'am.
Am I audible?
Yes, ma'am, you are.
Good evening, and good evening, Dr. Jyoti. I think in this very short span, you could cover such vast topic. That is really hats off to you, and very important aspects. So we are really, and I hope that in future we should be able to arrange little, maybe sparse more topics. Okay, so that you don't have to rush, and it could have been much more useful. So next time, I believe we will try to see that aspect. Thank you so much. It was a wonderful session, and simulation is something that everybody is interested in. Thanks a lot.
Thank you.
Ma'am, dear participants, I take this opportunity to thank our resource faculty, Dr. Judie Arulappan, for her extensive, elaborative talk on simulation in nursing. To add on, I think all of you will know, ma'am is the author of Wong's Nursing Care of Children, Southeast Asian edition. Her expertise and in-depth knowledge is very much evident from the explanations that she has given. A very big note of thanks to the CNRS North Zone President, Dr. Lata Venkatesan, and Vice President, Dr. Kamlesh Kumari Sharma, and all the executive members and CNRS head office executives, CBS publishers for their technical support, and all of you participants. I have a request to all the participants. Participants, please become members, life members of CNRS, and appreciate your growth and contribution to the profession. Ma'am, you want to say something, Judie ma'am?
No, I would like to thank everybody. I was reading the chat. I was just looking at the chat, whether I missed any information. I was just looking at the chat. I hope I answered all their questions.
Yes, ma'am. You have answered
all
all the
questions. Any further clarifications, I have already provided my contact details, so they can be in touch with me. So thank you for the opportunity again.
Ma'am, to your knowledge, that around 300 participants participated in this webinar.
Excellent, excellent. Thank
We
you
had
so
a
much.
good
I'm
number.
so glad. I'm so glad because I could reach out to many people. Thank you so much.
Thank you, ma'am, and thank you all dear participants. Have a happy weekend.